So I'm supposed to speak on the avulsion fracture. Very difficult to define an avulsion fracture in a distal radius because uh, any mechanisms that we have thought about in distal radius and read about, rarely we will ever see avulsion as a mechanism of injury in distal radius. So how does an avulsion fracture occur? Either it happens, too much help. This was my boss who used to always say when we were operating and trying to help, detract too much or trying to, he'll tap on the hand and say too much help. So an avulsion fracture happens either when a muscle pulls onto the bone and fractures it, or a mechanism of injury in which a spur of bone is pulled out because of a traction through the ligament. And the commonest varieties that we see is the olecranon, which is an classical avulsion fracture because of the triceps pull. Then a medial malleolus because of the traction to the deltoid ligament. And then, of course, ulnar styloid. Ulnar styloid almost always is an avulsion fracture which happens through the dorsal and the volar radioulnar ligament, that is TFCC. And for that, the radius essentially has to be fractured. Same way as, whenever there's a medial malleolus fracture, you always suspect some injury on the lateral side. Either there's a fibula fracture or the talus has shifted because of the ligamentous injury. So there will always be a matching injury, whereas in a muscle pull injury, there will usually be a single mechanical factor. And these injuries require what is called as a tension band wiring. Tension band wiring is a principle that is used when there is an active muscle pull. So every distraction force, when the person actually now flexes and the triceps tends to pull out the fracture, it is converted into a compression force. Whereas ligament avulsion injuries, we don't use the word tension band, we use a traction absorption system. So that's a traction absorption system on the ulnar styloid, and that's on the medial malleolus. The reason I'm telling you all these things, these are when similar injuries happen on the distal radius, you still need to apply the same principles, and they are not very common. They are not very commonly applied on the distal radius, and therefore I just thought I will touch upon these. So for muscle pull, tension band; for ligament pull, traction absorption. Different types of traction absorption. It can be a tension band wiring like a construction, or it can be a compression screw. So why these small fragments cause big problems? Because they're essentially very, very unstable. Because all these small fragments in the distal radius are a result of ligamentous injuries. Radius, the wrist joint on its volar and dorsal side is covered with ligaments. There are very few areas of the ulna and the radius rim of the dorsum and the volar side which are free of ligaments. Dr. Greg Ben published this paper he said that most of the fracture lines that you will see in the distal radius are a result of fault lines. Fault lines, which are areas of potential weakness between the ligamentous attachments. So if you see the distal radius surface, those circles are the potential weak areas where the ligamentous attachments are missing, and they create the fault lines. And therefore, most of the fractures that you will see in the distal radius will be along these lines. And you will agree, those who see CT scans, axial cuts quite regularly, most of the distal radius fractures will fall in these patterns. When the uncommon fracture patterns, which are a result of ligament avulsion, which are rare, mind you, it's not very common to have a true avulsion injury in the distal radius. It will again follow the pattern of these ligamentous attachments. And these are the three common patterns that you will see in avulsion injuries: styloid, the volar lunate fragment, and the dorsal long shear injury. These are the three common patterns you will see. Dr. Abhijit Vahegaonkar, my good friend from Pune, has gladly accepted to allow me to share this case. So this is a dorsal shear fracture, needless to say. And as I said, one of the three structures that we talked about, volar lunate, the styloid or the dorsal shear has to be fractured. Most of these are reducible but highly unstable. So the best way to assess this injury is to assess them under anesthesia, reduce it, and then plan your fixation. Okay. So you can see that the styloid is missing. Okay. The styloid fragment. So this tells me that the ligaments which are attached to the styloid fragment and the carpus have moved together. Now this injury is like breaking of a bangle. It can never break only at one point. There will always be another injury which you are not seeing. And this another injury usually is a periosteal sleeve avulsion. So there is a fracture on one side and there is a periosteal sleeve avulsion on the other side, which leads to subluxation in a particular direction. So if you see, that was the reduction, and that is how the ligament was pulling the fragment. And when we saw it, so that's the instability that you will see. Okay, if you keep it compressed on the articular surface, it remains. And that was the instability. So needless to say, once this compression, Okay, so this is where the injury was, the styloid. And that was the ligament that was responsible, radioscaphocapital ligament, one of the strongest ligament on the volar side of the wrist. And that took the entire carpus with it. So as I said, this fragment needs to be compressed in place in order to negate this avulsion force, which was fixed with a headless compression screw. And with the same force that was displacing the fragment now it cannot be further depressed. So a preferred method of fixation for avulsion injuries is to compress them in place by whichever method you may choose. It requires a very secure fixation. Unlike a large volar Barton fracture where you could get away just by buttressing, okay, these tiny fragments need to be securely held. Another shear fracture, obviously a volar shear fracture. So one of the volar structures is injured. Orthopedic surgeons are ever optimistic. Optimism is good. This did not work on this in this fracture. It slipped, and as I said, it's a volar shear fracture. Almost the entire volar rim is fractured here. Okay, so the entire volar rim is fractured, and therefore the entire carpus shifts volar. And all these fragments are each having a very important ligamentous attachment to it. The radial styloid, the radioscaphocapital ligament, the intermediate rim where the radiolunate ligament is attached, and the ulnar corner where the TFCC is attached. So that is how it looked. That entire rim of the radius was sheared, and the only method of fixation which could securely hold it in place was ethibond sutures through those ligaments. So when you place ethibond sutures through all the ligaments that I just showed, that gives you excellent control over the shear fragments, and you just now need to make sure that the sutures are held to place to the rest of the radius, and that can be done by weaving them through a plate, and this way you can use it. So as you can see, there are no screws in the distal fragment, but it still goes on to heal very, very well. Slightly more severe injury of volar shear, as you can see, the lunate with the teardrop. You can see the teardrop is missing from here. The lunate with the teardrop is missing. The styloid is in place. The styloid looks intact. So it's essentially the volar lunate fragment that is avulsed. So it is this volar lunate fragment. Now this is also called as the cornerstone of the distal radius. This is, if this one tiny chip of bone that comes off from the distal radius, it will take the whole carpus and the lunate with it. Okay, so that's the one which is sheared, and it needs to be put in place. Again, if you don't have special plates which are designed for this purpose, you can use the same method which I just showed. Put ethibond sutures through the ligament, okay, and weave it through the plate and put it in place. Now, when you have more of a ligament injury and very tiny bones, and which you are forced to immobilize them for a long period of time, you do end up with a poor outcome. This man has a painless and stable wrist, but a very, very poor range of movement. One more very, very severe case, a motorcycle accident, young fellow in his 20s, very difficult to classify, but you can see that there is a large chunk of bone here, okay, which is a styloid fragment, and lot of bone that is stripped off from the radius. Very, very severe injury. So you have a styloid fracture and a periosteal sleeve that is stripped off from the volar rim. Again, the entire ligament complex has been avulsed. Very, very unstable injury. It was an open fracture. As I said, optimism. There was an attempt made to close reduce this in the casualty. Extremely painful. He also had other injuries. He had a femur fracture. So he came in, I think, a day later for his wrist surgery. The entire flexor mass had migrated between the radioulnar space. That is what made, including the median nerve, that is what made the reduction very, very difficult. So even open reduction, it was highly, highly unstable. This is how it looked, the distal radius. And then when the distal radius was put in place, it had to be held with a temporary radioulnar wire. There were few more wires that were passed from the styloid into the carpus and of course the radial styloid. And then you can see what I'm holding with the forceps is the periosteal sleeve. Is it, can you appreciate it really? I'm holding the periosteal sleeve with the forceps. So that's the periosteal sleeve in place. That's the is it now? This is more clear, is it? Yeah. Yeah. Okay. And the wire is in the lunate corner of the radius in the intermediate column. Yeah. Now it's in place, and then it was sutured with anchors. That's how it looked post-op. And late post-op, this is how it looked. He had a very bad infection. The entire fixation walked out, and then he needed a wrist arthrodesis, and then he was lost to follow-up. In Mumbai, when a distal radius is lost to follow-up, they land with Dr. Warrior.
For a little time.
Well, he hasn't come back. So when these patients don't come back, I actually feel very happy because they are in good hands. They are in better hands. And many times when I sense that the patient may not come back, I actually tell them, this is the number. Please take an appointment and go here if you are thinking of going anywhere else. Sir. So dorsal shear injuries more uncommon as compared to the volar shear injuries, and with this article really talks about the variable amount of volar injury that you will have with a dorsal shear fracture. As Kiran, I think Kiran did mention this in his talk, there will always be variable degree of volar injury when there is a dorsal shear fracture. And this article talks about when that volar injury requires to be fixed. Now, to put it very simply, I don't want all of you to go back and read that article. That will hamper my bread and butter. Once you do compression of the dorsal shear fracture, please assess the stability of your construct. If there is any doubt about stability of the carpus on volar and dorsal shear force, even if there is no fracture on the volar side, if there is an instability, please go on the volar side, anchor the ligaments, put a plate and put suture through it. Do not leave a potential instability there which is going to compromise the overall function of the wrist. So this is just one example, a large dorsal shear injury. Please don't say, I'm now going to hear some sighs after this X-ray. Okay, this is the type of injury that he had. Lot of metal. I know. I almost guessed this reaction.
At least you should have spared the staple.
The staples typically come in when I am 1 hour and 25 minutes into tourniquet time, and then I have a choice of suturing after letting down the tourniquet or just putting quick staples. So, just to explain, we started with the volar buttress for the volar shear, and the carpus continued to be unstable. Sorry, I started with the dorsal buttress. I'm sorry. Started with the dorsal buttress. So there is no fixation on the dorsal side. It's just a dorsal buttress plate. And then it continued to be highly unstable even on the volar side. So I had to put some capsular sutures on the volar side. Okay, that's the reason you see plates on both sides. So small fragments, they're highly unstable. They cannot be left alone, however innocuous they look. There will always be a variable degree of volar plus dorsal injury. It's almost never alone. They require very, very secure fixation. They cannot be just pushed in place and left there because there's a strong ligament attached to it. With movement, those are going to get avulsed again. And bony avulsions, like a large bone-to-bone healing, will always give you better outcomes in terms of range of movement as compared to pure ligamentous avulsion, which you tend to immobilize for a longer period of time because of their slower healing. Thank you very much.